Perfect. Thank you again, everyone, for joining us today. I'll go ahead and get started this afternoon. My name is Matt Lopez. I'm the Regional Sales Director for Levo Medical, and I'm pleased to host this webinar today on tinnitus acoustic stimulation, customized versus non-customized sound. I'm pleased to be joined today by our two panelists, Dr. Daniel Drexler and Dr. Richard Tyler. Dr. Drexler is our Levo Medical's clinical director and original founder of the Levo system. He comes from Montevideo, Uruguay, where he's a founder of the Central Tinnitus de Montevideo Tinnitus Clinic, running a multidisciplinary approach to treat his tinnitus patients, and happy to have him discuss his thoughts today on Levo and customized sound. Our next speaker obviously doesn't need to be introduced. Dr. Richard Tyler, professor research from the University of Iowa. As we all know, Rich has had many contributions to the tinnitus and hyperacusis world throughout his professional life, and we are very pleased to have him join us today to talk on various topics in the tinnitus space. With that, I'd like to turn it over to Dr. Tyler, and he'll move forward with the presentation. Rich?
Okay, greetings, everyone. Glad to be part of this and hope this is helpful. So I want to start off with just explaining what we refer to as the psychological model of tinnitus. And that is, it's very important to make the distinction between the tinnitus itself. It has a different pitch and loudness and quality different in different people. That's the tinnitus characteristics. And depending upon various things, the tinnitus can be annoying for a lot of people. And that's separate from what the actual tinnitus sounds like. So you have the tinnitus itself, and then you have the tinnitus annoyance. How bothersome is the tinnitus? And the annoyance of the tinnitus is influenced by, for example, the loudness and what it sounds like, but it's also influenced by the individual that's experiencing this. Generally speaking, the psychological characteristics of the individual. So we all have different stresses in our lives, and people might have problems with their health and how long they've had this for, what their perspectives are of things. So the ability to cope with the tinnitus is influenced by the tinnitus itself, and also how annoyed they are, but also the psychological makeup and experiences of the individual subject. So that's very, very important. So you have the tinnitus, you have the psychological makeup of the individual person, and those two factors, separate from each other, actually determine how annoyed the individual is going to be. So that's important to understand the whole person, not just the tinnitus itself, but understand that individual, where they're at in life, what they've gone through, what their health is like, and just in generally, where they're at as a person. And that is going to have an effect on the annoyance. So you have the tinnitus, you have the tinnitus annoyance, and both of those things are influenced by the psychological characteristics of the patient, the annoyance, by the characteristics of the tinnitus, and by the background of the individual and what they've been through already. So in helping these patients, it's really important to understand the individual patient. And what that means is apply that psychological model, see how bothered they are, see what their life is like. We're all different. Everybody has a different background. And so as a first step, it's trying to understand where this patient is at. And that might even be why they're there, what do they expect of you. And the second point in this initial connection with the patient is to make sure the patient respects you and your expertise. You need to be seen as an expert in providing tinnitus help. And there's a variety of ways you can do that, but obviously part of that is just by understanding the patient, by having a respectable office, perhaps by having a certificate on the wall. But it is really important that the patient believes in you and understands that you care about them and that you have experience and expertise in helping tinnitus patients. The next thing is to have good counseling options. And the one that we have developed here, we refer to as tinnitus activities treatment. And that focuses on the thoughts and emotions, sleep, concentration, and hearing, depending on the individual needs of the patient. So having a clear strategy to provide counseling for these patients, in addition to providing hearing aids and sound therapy devices. If you're an expert at helping people counsel tinnitus patients, and that can be difficult, but it also can be helpful to understand what the options are and to work through with the individual patients. And we don't have any magic wands either, but so we all need to be good listeners, but we can all help our patients. And we have produced tinnitus activities treatment that can be available to you to help your tinnitus patients. The fourth thing is to appreciate for you and for the patient that letting them know that background sound can be very, very helpful for most patients. So you can imagine, your tinnitus patients really complain of their tinnitus in quiet when they first get it, when they try and go to sleep at night and they're in a quiet bedroom, and the tinnitus is there, it's standing out on its own. So having some background sound that masks or partially masks the tinnitus, makes it less loud as a distracting background sound, can be very, very helpful for most tinnitus patients, background sound therapy. Okay, so we always say the most important thing when you're getting started here is to connect with the patient at that very first meeting. So what that means is that you need to be, as I said, seen as a professional. You also need to be a good listener and show the patient you care and connect with them. And so that doesn't mean you need to start lecturing to them right away. It's important to understand them where they're at. And what that means is, for example, to let them know that it's reasonable that you're concerned about this. It's not supposed to be there. Why is it there? What's going to happen? Is it there forever? What can I do about this? It's reasonable that you're concerned with your tinnitus. Lots of people have this, but because it's invisible, you probably have friends with tinnitus, but you don't even know it. It is reasonable that you're concerned, and for most people, the first few weeks or the first couple months are the worst. But after you realize that you're not alone, that there are some things that can be done, that we're here to help you. So just connect with the patient, express to them that it's okay with them, that they're upset. That's a reasonable, rational response, and that you are here to help them. And then it's important to move on and understand completely what difficulties they are experiencing. So how has your tinnitus affected your life? How long have you had it for? What's changed? Are you living with a partner? Do they understand? How are they reacting? So that first step there of connecting with the patient and understanding where they're at, understanding what difficulties they're going through, is a very important first step to help moving forward. So we have developed what we refer to as the Tinnitus Primary Functions Questionnaire, and that's been translated into several different languages. And again, it focuses on the 4 different areas that tinnitus can affect people: thoughts and emotions, sleep, concentration, and hearing. So after taking the Tinnitus Primary Functions Questionnaire, we can see what areas they're having problems. So most of the patients that you see will have problems with thoughts and emotions. You're upset with it. Most of them will have hearing difficulties, and the Tinnitus Primary Function Questionnaire attempts to distinguish the hearing difficulties caused by hearing loss, which most of them will have, and the hearing difficulties caused by the tinnitus. So if you're hearing a background noise or a ringing sound, it's not unreasonable that that's going to get in the way of you understanding speech. So thoughts and emotions and hearing are quite common. You want to try and see if you can distinguish whether the tinnitus is also affecting their hearing. The other areas affected are sleep and concentration. So again, as I mentioned, they're going to sleep at night, quiet bedroom, lights are off. All they hear is this ringing sound that they have no control over. So sleep is a very common problem, but not everybody. And then concentration. So they're trying to read a book, they're trying to focus on a hobby, and this background ringing sound is distracting. So helpful to distinguish whether concentration is actually having an effect on being affected by their tinnitus. So the Tinnitus Primary Function Questionnaire helps connect with the patient, shows them that it's reasonable to be affected in these 4 different areas, finds out which areas are affected and which ones are not so prominent. And from that, you can move on to tinnitus activities treatment in the areas that are affected for that individual patient. So these are some examples from that. When your tinnitus began, what was your home like? What was your life like at home, at work, etc.? So this is in our tinnitus activities treatment. This is an example. So we want to know where the individual patient is at. When your tinnitus started, what was your life like? How has it been changed? What were things going on for you at home, at work? And now you've got this sound you have no control over. How has your tinnitus been changed? Are you having trouble concentrating at all when you're trying to focus on something? What about when you're trying to listen to somebody and interact? How about when you're trying to sleep? A lot of people tell me that when they go into the quiet bedroom, the tinnitus is there. And are you upset by it? Do you wish it would go away? We're here to help you. And it affects people differently in different forms. But we have counseling skills, we have sound therapy, we have hearing aids. So we can help you in lots of different ways. We're glad you're here, and we hope you can be helpful. Another question is, we often ask the patients is, how do you think we might be able to help you? We sometimes ask this right at the beginning of connecting to a patient. We don't have a magic pill either, and some of the patients have already been 10 places. Some patients have already tried 10 different pills. And so then what do you do? There is no magic pill here at this point. And so it's important here to be a good listener. So perhaps in one of those first times you're meeting with the patient, how do you think we might be able to help you? What have you tried before? We're glad you're here. We'd like to know more about what your expectations are, what you've tried already, and how you ended up coming to see us today. So the tinnitus primary activities slides are available for free at our University of Iowa Department of Otolaryngology website. You can just search that online. There's the website down below, but you can also just search it. So we have our counseling slides for thoughts and emotions, hearing, sleep, and concentration. We also have different translations of our tinnitus primary questionnaire, and that's an important place to start to move forward. So these are all available on our department website.
All right. Thank you, Dr. Tyler, for sharing this information. Very helpful and informative. And again, that website is available to get those additional resources, and we can certainly hand those out if you have any follow-up questions as well. One thing I forgot to note is we will have some time at the end of this webinar for some Q&A. So if you do have any questions for either Dr. Tyler or Dr. Drexler coming up, please feel free to write those down and we'll facilitate those at the end. At this time, we're going to segue into discussion about customized versus non-customized sound therapy and bring in Dr. Drexler to share some additional slides on that. Dr. Drexler?
Hi, how are you? Well, it's a pleasure to be with you today, and it's also a pleasure to be with Professor Tyler in this webinar. We are going to discuss the differences between customized and non-customized sound therapy. There are different strategies for acoustic stimulation. We can divide them in many different ways. One of them is between customized and not customized. And the biggest difference is that the customized sound therapy designs sounds for each one of the patients, taking into account the characteristics of the tinnitus of the patient. It can take into account characteristics related to the frequency components of the tinnitus or also to the intensity. The purpose in non-customized sound therapy is to improve adverse psychological and emotional reactions by masking the tinnitus. While in customized sound therapy, the purpose is to achieve neuroplastic mediated changes that reorganize the auditory pathways and all the net that is involved in tinnitus. Not only the auditory pathways, but also the connections between the cortex and the limbic system and the parasympathetic system. I mean, all the nets that are involved in tinnitus. Next one. The goal in the non-customized is to help the patient to become accustomed to their tinnitus and to make it easier for the patient to keep on his life with the tinnitus. While in the customized sound therapy, the goal is to achieve a reduction of intensity of the tinnitus and also desensitization for tinnitus. I mean, this also is a goal in the non-customized to achieve desensitization. Next one. Regarding the type of sound, in non-customized, the sound is unmodified music, noise, or environmental sounds like the sound of the wind or of the sea. While in customized sound, the sound is designed for each one of the patient based on the individual tinnitus characteristics. Next one. The precision of acoustic pattern is highly required in customized sound therapy, while it's not required in non-customized sound therapy. And the brain reprogramming, I mean, this is a very strange way of saying it. It's not brain reprogramming, but it's trying to get changes inside the net that will endure even after we stop the stimulation. And it's of course different in non-customized. There's no achievement of those kind of changes in the net, while in customized sound therapy, the aim is to achieve them. Next one. Well, regarding non-customized sound therapy, there are noise generators, bedside noise generators, music, etc. And of course, this is done at the same time that some kind of counseling is delivered to those patients, for example, like TRT or the CBT. But the type of sound is this kind of sounds that they are not designed precisely for each one of the patients. And of course, the other big tool that we have for non-customized sound therapy are the hearing aids. Next one. And I wanted to stop just briefly on the hearing aids because in the States are one of the first lines of treatment for tinnitus patients. And this can be understood if we understand that just reported that 80% of tinnitus sufferers present some form of hearing loss. I mean, all the patients that have tinnitus, if we look them in a very precise way, we will find that they have some degree of hearing loss. Even sometimes this hearing loss doesn't appear in the audiogram, but if we check other studies, for example, autoacoustic emissions, especially the transient autoacoustic emissions, we will find that there is a small notch in the frequencies that are involved. But there's a study from 2012 from Kochkin that reported that 44% of the patients in the United States reported no hearing loss. I mean, when they were asked if they had hearing loss, they reported that they don't feel hearing loss. And at the same time, the same study reports that around 50% of the patients with tinnitus don't find relief using the hearing aids. There's a large percentage of patients with tinnitus for whom hearing aids would not provide an efficient solution. And I'm not saying that hearing aids are not a wonderful tool. We use them a lot here in our clinic in Montevideo, but there are some patients that will have a benefit from hearing aids and other patients that would need a different strategy. Next one. So there are also many different strategies for customized sound therapy. For example, tinnitus pitch match therapy, in which the sound reproduces the characteristics in frequency components and intensities of the tinnitus of the patient. Tailor-made note music training, Heidelberg neuromusic therapy, acoustic coordinated reset neuromodulation therapy, and modulated wave therapy. There are different strategies that can be used to achieve customized sound therapy. Next one. But there's a part of the tinnitus research community that is starting to support that there is a greater tinnitus suppression effect when you use customized sound therapy. And of course, there's a strong consensus also for customized and non-customized that counseling combined with acoustic simulation yields the most promising tinnitus treatment results. The combination of the two strategies, one that tends to create changes in the tinnitus through acoustic simulation and counseling, achieve the better results in tinnitus therapies. Next one.
Thank you, Dr. Drexler. I just wanted to bring in Dr. Tyler for a quick sec here and ask specifically when it comes to sound therapy, Dr. Tyler, what are some recommendations you share with your patients, you know, as they approach their protocol within the therapy?
Well, I think that starting off just saying that, you know, there's no magic wand here, but there are a lot of patients, most patients benefit from having some low-level background sound, just generally speaking. And so, you know, if your tinnitus sounds like a whistling sound or something like that, then it's reasonable that you're upset like that. But if there's some background sound, waterfalls or raindrops in the background, then our brain finds it easier to ignore those sorts of background sounds. So the background sound, generally speaking, has great potential to make the tinnitus less prominent. And so that's been the approach for many, many years that Jack Vernon started. He took me to a waterfall, a fountain in Portland, Oregon, and he said, this is the only place where a patient has brought me and said, this is the only place where the tinnitus isn't prominent anymore. And that's what led Jack Vernon to actually start wearable tinnitus maskers. So different in different people, but it's quite reasonable that the tinnitus stands out there on their own. And having some low-level background sound can be partial masking or distracting. And it also gives the patient some control instead of being completely helpless. They're now part of the team to actually make their tinnitus less prominent.
And so, just as a general follow-up, when it comes to specifically customized versus non-customized sound, is there a particular patient you feel would benefit more from a customized type sound for their therapy?
Well, I think that, again, all the patients are different. So, a first step is just connecting with the patient and see where they're at. It may very well be that that if they feel if they can be involved in it, that's going to put them more in the driver's seat, so to speak, and make it more part of their approach. So if they're participating, it may very well be that's going to be more helpful. There are some patients who don't know what to do and aren't sure and certainly need your guidance as a clinician. So it's going to depend on the individual patient. And then in addition to that, because there are different mechanisms of tinnitus, it may very well be that some specific approaches, such as the one we're talking about here, might actually be more useful in changing the neurophysiological patterns that is causing this tinnitus. So different in different people. We have to go slowly and understand where they're at, but there is some great potential here for trying to be specific.
Excellent. Thank you. Appreciate that there. Dr. Drexler, I'm going to pass it back to you. He's going to share a few slides on some data on the Levo system, and then we'll come back to a few questions with Dr. Tyler.
Yes, before that, I want to ask Tyler, because I heard a legend that I never came to meet Vernon in person, but he had a fountain in front of his office, and there's like a legend that he used to receive the information from the patient that while they were waiting for getting inside the office, this fountain reduces the intensity of the tinnitus and the suffering. So this is also something that got him into thinking. I've never heard about this waterfall. I've been to the same waterfall in the Columbia River, but I never heard that it was in the waterfall.
Yeah. Well, Jack was doing physiological research at the time and had many people calling him because there were so many people desperate. And one of them took them to one of the fountains that produced a lot of background waterfall type sounds, and that's what helped them, and that's what gave Jack the idea to move forward.
Thank you.
Great. Okay, let me share my screen here, and then we'll move on to the studies here.
Well, this is the results of a study that we performed on 12 patients. And what we have here on the left side is the intensity reduction over 12 weeks of stimulation, in which we achieved a reduction, an average reduction of 14.1 dBs from around 58 dBs pre-treatment average to an average post-treatment around 44 dBs. But at the same time, what is interesting is that we detected that there was a strong correlation between this intensity reduction and the reduction of the scores of 3 different psychological tests that we performed simultaneously: the Tinnitus Handicap Inventory, the Tinnitus Reactional Questionnaire, and the TFI. In all those tests, we achieved significant reductions. And next one, please. Regarding the reduction of the scores, in the THI, it was from around 46 to around 15. In the TRQ, it was from around 24 to between 5 and 10. And the TFI, it was between 55, 56 to around 7. But what was more surprising for us is that when we looked at the subscales of the TFI, particularly at the sleep subscale, because this subscale was very important for us since our therapy is performed during the night, we saw that there was an average between before the therapy of 68 points, and after the 12 weeks, the average was of 13 points. And we all know that there's a strong correlation between sleep and tinnitus, as Professor Tyler was saying at the beginning. One of the 4 items that he uses in his test is about sleep, because addressing sleep is very important for us. If sleep gets worse, tinnitus gets worse, and if tinnitus gets worse, tinnitus makes sleep more difficult. So there's a kind of vicious cycle between tinnitus and sleep. So it's very important for us to understand if we can achieve a way of improving the sleep quality of the patients. And it was very important for us to see those results. Next one, please. So this was the intensity reduction achieved from 58 dBs average pre-therapy to 43.9 post-therapy. It's a 14.1 dBs reduction, and we know that every 10 dBs of reductions, there's a reduction in perception of 50%. So if we achieve a reduction of 14.1 dBs, the reduction of perception achieved is 62%. That means that the tinnitus that was light in front of the eyes of the patient now is no longer sensitive, is reduced. This helps a lot also because the patient is not aware of the tinnitus during the whole day. Many times when the tinnitus is below the sound of the environment, the patient doesn't feel the annoyance of the tinnitus, and also in the night, even if he still hears the tinnitus is not so detached from the sound floor of the environment. So it is easier for the patient to cope with the tinnitus. Next one. Those are results of a study performed by Theodorov et al. In 2017 in the Portland VA hospital. Is the group of Dr. Henry, and they divided a group of patients of 60 patients in 3 groups of 20 patients each one. The first group was treated with the bedside sound generator. The second one was treated with the level system, but not using the customized sound. That means the patient slept with the level system, but using a sound of his choice, like wind or sea sound or rain sound or something like this. And the third group was treated with the level system, but with the customized sound. And what is interesting here is regarding the numeric rating scale, that is the first one that appears here on the left on this graph, those patients that used the tinnitus, the customized sound with the level system were the ones that achieved best results. Also, the patients that used the level system achieved better results in the reduction of the TFI, but there was no significant difference between those that used the customized against those that didn't use the customized. So the results here are mixed. In one part, those results sustain the idea that customized sound is more efficient in inducing changes. And on the other side, on the result of the TFI, the results were not so clear. Next one, please. This is a data analysis we are currently performing in Centro de Tinnitus Montevideo on 60 patients that used the system between 2015 and 2022. And what we saw is that after 9 months of using the therapy, 9 months of therapy, 15% of those patients achieved no intensity reduction, but the rest, the 85% of the patients achieved a reduction of intensity of the tinnitus to 5 dB, 32% between 5 dBs to 10 dBs, and 25% above 10 dBs. And here, I want to recall something that Dr. Tyler said. All the tinnitus are different. We still don't know a lot about the different physiopathological mechanisms that are behind each one of our tinnitus. And I hope that in the future, we will understand why there's almost 25% of patients that have a very good and sharp reduction of intensity, and we have another patients that don't have this kind of intensity reduction. And also why in 15% of our patients, we didn't achieve any reduction at all. So I strongly agree that every patient is different, that we should understand different strategies that we need to treat our patients. And hopefully in the future, if we keep on making a lot of research, we will understand in a more precise way why, in which cases we need to use this kind of sound, or in other cases, another kind of strategy.
Thank you very much, Dr. Drexler, for sharing that information. Bringing back in Dr. Tyler here for a few questions before we open it up to the audience for Q&A. So again, if you do have any questions for our two panelists here, please submit those and we'll get to those in a few minutes here. But Dr. Tyler, just based on what Dr. Drexler shared, can you give us some of your thoughts on where you think Levo can fit into a tinnitus practice and see what kind of options there are for patients? I know you've mentioned quite a few, that every patient is different, but if you can just elaborate on that a bit.
Right. So I think that the results are very, very promising. It might be a good thing for various clinicians to become aware of what the options are. And as I said, it's good to have some options. All the patients are different. They have different needs, and or connect with you in different ways. So I can say at this point that the results are certainly going in the right direction, and patients might even come into your clinic asking for this. But it certainly is reasonable to consider this as an option. And I said the results are going in the right direction, and every patient is different, different mechanisms and different problems relating from it. Having some useful background sound in addition to the counseling is often part of the big picture in helping the patients.
Thank you very much. In terms of just overall your tinnitus patients, What's the best or most effective way you have found to track success throughout the protocol? Is it patient interaction, different questionnaires that you recommend, or what is the process you take in terms of measuring success?
Well, certainly if it's it depends if it's a research study, then a lot more questionnaires and measurements have to be made on a regular basis. But I'm going to say that for the tinnitus patients, that may or may not be effective, and it may very well be that you don't want to be reminding them about all the challenges that they have for their tinnitus. However, certainly as a first step to connect with them, to show them that you understand tinnitus, to show them that tinnitus can indeed cause different problems, using something like the tinnitus primary function questionnaire can help connect to the patient and help them see that they indeed do have challenges that are not uncommon for people with tinnitus. And then following the treatment, as we saw today, doing the questionnaire over again, or even partway through a treatment, and again, every patient is going to be different, but showing them partway through over a month or over 3 months that things are getting better. That's going to help you again connect with the patient and show you which areas are being beneficial and which ones are not, maybe, and just provide more connections to the patient. So those, our tinnitus primary function questionnaire, I think, really guides clinicians in terms of their counseling, helpful to show patients they're benefiting from sound therapy. We focus very specifically on that, on the problems caused by tinnitus. I've also noted a few years ago that a lot of the surveys done worldwide on understanding the problems, generally speaking, of the effects of tinnitus on the quality of life, unfortunately, those are not, the importance of hearing and communication and socializing are not captured in the quality of life scales. So we developed a new quality of life scale that we published a couple of years ago now called the meaning of life, which indeed appreciates more the importance of hearing and socializing and interacting with people and feeling positive about many more relative things. So I think that the questionnaires can actually help demonstrate that your devices are being helpful, and they can help you connect with the patient, showing that you understand all the problems that people have as a result of their tinnitus.
Excellent. Dr. Drexler, anything to add to that?
Well, I strongly agree that it's very important to understand in each case, for each patient, what is relevant for this patient in his life. Because what we are trying to do is to help him to reach a stage in which he can take on his life. We have many patients that the tinnitus is so annoying that they stop everything. I just saw today a musician, a very known musician from Argentina. He came to my office. He's one of the most known musicians in South America. And he told me, I stopped playing 1 year ago. I lost my life. So it's really difficult for him to keep on having a meaning for his life if he can't play anymore. So it's really relevant to understand what the patient wants and how can we help him, and to understand also that we are not magicians, and we don't have a way of giving a perfect pill that would take everything off. But at the same time, we have really make a lot of improvements in the last 20 years that make us possible to help the patient to change the intensity of the tinnitus, to change the impact of the tinnitus in his quality of life. And even if he doesn't stop hearing the tinnitus, he can regain his normal life and regain to do what is meaning for him in his life. So I think that it's very important. I feel that it's a promising moment because we are really developing new strategies that can help the patients. And I'm glad that there's a strong community that is working and thinking on tinnitus all year long, and we are starting to see very good results.
Excellent. Thank you both. question from the audience here, and I'll send this to you, Dr. Drexler. Contraindications for the Levo system per se. Any contraindications that you can think of?
There's only one absolute contraindication, is in those cases in which the tinnitus measured with our system is above 85 dBs, because our system has a limit of security at 85 dBs. Above 85 dBs, you may be in the situation in which you can create harm if you stimulate for so many hours. So the system is locked at 85 dBs, and this is the only really strong contra situation in which you can't use the system. In other situations, of course, there are situations in which the system gets better results. For example, a patient, a young patient, or a military person that has an acoustic trauma and a small notch in 4 kilohertz, okay, and is a young person, and the tinnitus has a recent onset. Of course, in those cases, we have the best results. And in the middle, you have a lot of different situations in which you achieve different degrees of improvement.
Question came up about a patient, if they're clinically or unmanaged clinical depression, anxiety, or suicidal thoughts. I'll ask you, Dr. Drexler, first on those patients, and then maybe Dr. Tyler, what your thoughts are on how you approach those type of patients.
Those are cases that happen a lot. There's a strong correlation between tinnitus and depression and anxiety. So at the beginning, when I started my practice, I felt very lonely because I didn't have a way to manage those kind of patients that are very difficult. I'm glad to know now that I have a psychologist, a psychomotricist, I have an audiologist inside the clinic, I have a sound therapy designer. So I have a wide team around me. And in those cases, of course, I need a lot of help especially from the psychologists and the psychomotricists to give support to these kind of situations. So in those cases, if you have the possibility of having someone inside your clinic to help you, to give an approach that comes from different angles for those patients, this is very good. If you don't have this possibility, I suggest to ask for help from other physicians in order to be able to support, because those are patients that sometimes are really challenging, and it's very difficult to go ahead with them alone.
Dr. Tyler, anything to add on those difficult patients, clinically depressed or anxiety, something that you do in particular for those?
Yes, I will agree with Dr. Drexler. It's very important and beneficial for you as a clinician to make connections with psychologists and psychiatrists in your area. And, certainly if a patient, and I've done this a couple of times, talks about suicide, you need to take them to a psychiatrist right away. But I'll also just add that making those connections with psychiatrists and psychologists can also benefit you, because they might see some tinnitus patients first. And if they know you're the tinnitus expert, they will bring their patients to you as well. So there's good interactions in both directions, establishing relationships with psychologists and psychiatrists.
Good point for both. Thank you. One additional question here on specific to Levo. Should patients try hearing aids first? What if they're stuck in that stigma or denial that they need hearing aids? What's your approach, Dr. Drexler, for those patients with Levo that may benefit from hearing aids but might not want to go that path?
Of course, if a patient is candidate for hearing aids, I may first put the hearing aids, and sometimes at the same time, depending on the emotional repercussion of the patient, we can start at the same time with Levo and the hearing aids, or we can start with the hearing aids and add 2 or 3 months later the Levo system. So the patient uses the hearing aids during the day, and before going to sleep, he switches to the Levo system. But of course, if a patient is not candidate for hearing aid, I will go straight for the Libo system. And in our practice, we have a lot of patients that come here that they don't have any kind of reduction of the thresholds, of the hearing thresholds in the relevant frequencies for hearing aids. I mean, they don't have reductions between 1 kilohertz and 4 kilohertz. So in those cases, they may not be candidates for hearing aids. We go straight for the Libo system.
Excellent. Thank you. Appreciate that. On that note, I think we have no more questions from the audience. Again, I just want to take this opportunity to thank you both for attending this webinar with us and sharing your insight. It's been very valuable and informative on my end. One question just came up before I stopped the introduction. How often do patients accept the tinnitus match signal? So in terms of Dr. Drexler, in terms of accepting that therapy on a night-to-night basis, what's been your experience with patients and their reaction to listening to that customized sound nightly?
Well, at the beginning, I started doing this. Well, I'm a bit old now. It was in 1998, so it was more than 25 years ago. And at the beginning, I was worried exactly about this same question. I mean, would the patients adapt to a sound that comes from outside that has the same characteristics of its tinnitus? My surprise now, after more than 800 patients that we have here in Montevideo treated, is that we may have some kind of troubles at the beginning of the therapy with the issue that the patient has to adapt to using hearing in-ears during sleep. So it may be a bit challenging at the beginning. It may take 1 month, 2 months, or also to the fact that sometimes the earbuds are big for their ear channels, or all those kind of issues, or patients that are old and they are not used to use an application that runs on the cell phone, and so they may have problems in learning how to use the device. But surprisingly, I may say that I don't recall many cases in which patients say that they were annoyed by the sound. It takes some weeks to adapt to it, but what most of them refer is that hearing the sound coming from outside and having the sensation that they have some kind of control over the sound because they see the intensity and how the intensity is changing night by night gives them psychological reinforcement and gives them relief. So this is something that I know that all around the tinnitus community was an issue. But my experience is you will be surprised by how the patients react to hearing their sound, their own sound from outside, and how many of them will say that that they feel relief when they hear that it's not being created inside the head, that it comes from outside. I don't know which is your experience, Dr. Tyler, with this issue.
Yes, I think that's reasonable.
Yeah. Well, on that note, I'd like to thank you both again for joining us today. Dr. Tyler, Dr. Drexler, thank you for your time. If any of you would like to reach out to me, my cell or email is there, or you can schedule a meeting on the QR code as well if you have any interest or questions about the Libo system and implementing it into your practice. At this note, we'll end for today, but again, thank you for joining us and hope you all have a wonderful holiday coming up. Thank you.
Thank you.